Welcome to our Illumina CENTOGENE joint webinar, using NIPT to screen for the most common fetal chromosomal abnormalities. In today's webinar, we have with us Christine Dalton, Genetic Counselor at Illumina, and Professor Peter Bauer, Chief Scientific Officer at CENTOGENE. They are going to discuss non-invasive prenatal testing, explain the technology behind it, and give us some counseling guidelines. It promises to be a very interesting webinar, so let them start.
All right, well, thank you, and hello, everyone. I'm Kristen Dalton, and it's my pleasure to be speaking with all of you today about non-invasive prenatal testing, or NIPT, which is sometimes also referred to as non-invasive prenatal screening or cell-free DNA screening. You just heard my disclosure, and that is I am an employee of Illumina. Illumina is a company that is recognized globally for its advanced next-generation genetic sequencing technology, which is used in various applications from agriculture to reproductive health to cancer. Illumina sequencing has been used in the majority of published NIPT samples to date, and we're proud of our role in advancing this test. So to start, I wanted to review the screening and diagnostic testing options for fetal aneuploidy, meaning chromosome abnormalities, such as trisomy 21, which is Down syndrome, trisomy 18, and trisomy 13. So next slide, thank you. So there are several options available for screening and diagnosing fetal aneuploidy during pregnancy. Screening options, which are shown in the middle of this slide, include the first trimester combined screen, which is based on maternal serum markers and the ultrasound measurement of the fetal nuchal translucency. If the first trimester combined test is not performed, a second trimester maternal serum screen, such as the quad screen, might be offered. A significant disadvantage of these traditional screening tests is a relatively high false positive rate of approximately 5%. Also, these traditional screening tests provide a numeric risk for a limited number of aneuploidies, and they can only be performed during rather short, specific windows of time during pregnancy. If the traditional screening test result indicates a high risk of aneuploidy, or perhaps if the woman has other risk factors for fetal aneuploidy, she is typically offered diagnostic testing. This can be chorionic villus sampling, or CVS, which is performed in the late first trimester, or amniocentesis, which is performed in the second trimester. While CVS and amniocentesis are considered diagnostic and more accurate than screening tests, they are associated with some risks, including a relatively small but real risk of pregnancy loss or miscarriage. And like the traditional screening tests, they can only be performed at certain times during pregnancy. With the introduction of NIPT, women have access to a proven superior screening test that can be offered early in pregnancy, starting as early as 10 weeks gestation and then throughout the remainder of the pregnancy. Next slide, please. So these disadvantages of the traditional screens and diagnostic tests that I just reviewed highlight some of the goals and advantages of NIPT. One of the primary goals of NIPT is to reduce the exposure of the fetus and mother to the risks associated with CVS and amniocentesis. And NIPT can achieve this by having a significantly reduced false positive rate compared to that 5% false positive rate of traditional screening tests like the first trimester combined screen. NIPT should be, and it is, a test that can be offered easily to pregnant women. It's a blood test, which, as I mentioned, can be offered throughout pregnancy starting at 10 weeks gestation. And all of these goals should be met while still providing a high detection rate. NIPT does achieve this as well, and I will show that data later. Next slide, please.
So, warm welcome from my side as well. I'm Peter Bauer at CENTOGENE, a human geneticist, and so for us at CENTOGENE, this new NIPT testing really is one test among others that we can offer for the question before, during, and after pregnancy. And it just, as Christine pointed out, fills the gap where we can bring down risks for pregnancies and increase the knowledge we can gather very early there. But be aware that before pregnancy already some carrier screen questions might arise to be aware on heritable risk for children. And of course, if any test, such as the NIPT, shows abnormalities, we have a whole portfolio of single gene and screening methods to go after validation or further analysis, even in case if a pregnancy is abnormal, but NIPT is normal. So there will be always a differential diagnosis which can be addressed and answered with our technologies. So, and we do not stop during pregnancies, as CENTOGENE is giving genetic analysis and knowledge from birth throughout life. Of course, we will address and offer you a follow-up as well after the pregnancy for any question that might be related to genetics. So that's an intro from the perspective how to embed this test into a broader portfolio. And so with having said that, we can now have a look at the technology and performance of NIPT.
Great. So to provide some background for everyone, all of the NIPTs analyze cell-free DNA to learn more about the chromosomal status of a pregnancy. So in every person's blood, there are whole intact cells and small fragments or pieces of DNA that are referred to as cell-free DNA fragments. These cell-free DNA fragments are released into the bloodstream when the cells have broken down by the natural process of apoptosis, or cell death. So in the blood of a pregnant woman, and that's represented by the image in the far right-hand side of this slide here, the cell-free DNA in the pregnant woman's blood is a combination of the woman's own DNA, which is shown here in red, and DNA coming from the pregnancy, which is shown here in blue. Most of the cell-free DNA in a pregnant woman's blood is actually maternal cell-free DNA. Approximately 2 to 20% of the total cell-free DNA is from the pregnancy. This is known as the fetal fraction, or the percentage of the total cell-free DNA in a maternal blood sample that is coming from her pregnancy. So all NIPTs analyze all of this cell-free DNA together, the maternal and the fetal cell-free DNA. But an important point to understand is that the fetal cell-free DNA, or what we refer to usually as the fetal cell-free DNA, is actually coming from the cells of the placenta, specifically the cytotrophoblastic cells of the placenta. These fragments are not directly from the fetal tissue. But these cell-free DNA fragments can still be used in NIPT because most of the time the chromosomal makeup of the placenta is the same as the chromosomal makeup of the fetal tissues. However, in a minority of cases, the chromosomal makeup of the placenta may actually be different from the chromosomes of the fetal tissue. This is relatively rare, but it does occur, and it is a limitation of all NIPTs. This mosaicism or discrepancy between the placental tissue and the fetal tissue might explain some false positive and false negative NIPT results. And this is one reason why NIPT is considered a screening test, not a diagnostic test. For those of you listening who are familiar with chorionic villus sampling, CVS, in many ways you can think of the cell-free DNA as being similar to the tissue that is obtained by CVS, which is essentially a biopsy of the placenta, with some of the same considerations and limitations. Next slide, please. So as you probably know, there are several labs that offer NIPT, and they have individual differences in how they perform NIPT and analyze and report results. These differences are important, and it's essential for you as a provider to understand some of these differences and how they may affect how you use NIPT in your practice. CENTOGENE, which is powered by Illumina, uses a whole genome sequencing approach. With whole genome sequencing, the cell-free DNA fragments in the maternal blood sample are sequenced or aligned or mapped to the chromosome region that they represent. So this gives precise counts of mapped fragments across the entire genome, meaning the regions of all of the chromosomes. This is not to scale, but in the image on the left-hand side, each column of little gray bars represents the cell-free DNA fragments that are mapped to each chromosome. The general principle is that if there is more than the expected amount of fragments from a chromosome of interest, say for example chromosome 21, then this increased amount would be detected by NIPT and interpreted as an abnormal result. In this example, let's say a trisomy 21 result. The data that's gathered by the whole genome sequencing of all of the cell-free DNA fragments is used to screen for chromosome conditions of interest and provides an accurate NIPT result. Whole genome sequencing allows this method of NIPT to have significant advantages over other methods, including the ability to add more conditions to the test menu, and it allows for a lower test failure rate. By test failure, I mean when a sample goes through the testing process, but a result is not provided. And I will show some data and discuss test failures in a little bit more detail later. Other NIPTs may use targeted sequencing, which only looks at smaller regions on the chromosomes of interest, and this is represented by the image on the right-hand side. These tests have a higher failure rate and a limited ability to add new content to the test menu. Next slide, please. There is one laboratory now using microarray technology for NIPT, and there are limited publications supporting the efficacy of using microarray for NIPT. The limited information that is available is based on chromosomally abnormal samples with an average gestational age of about 17 to 19 weeks. So it's unclear how effective this method is in detecting chromosomal abnormalities at earlier gestational ages. And those earlier gestational ages are really when most women are having NIPT. And also, there is a lack of peer-reviewed publications providing a thorough clinical experience review of NIPT using microarrays. There's also a targeted sequencing approach for NIPT using SNPs, or single nucleotide polymorphisms, which represent small, common variations in the genetic code between individuals. This method also has a higher failure rate, and it's not currently available to use for NIPT for women who are carrying twins, or women who have used an egg donor or surrogate, or women who have received a bone marrow transplant. Next slide, please. So many publications have provided evidence supporting the excellent performance of NIPT in screening for common fetal aneuploidies, including trisomy 21, trisomy 18, trisomy 13, monosomy X, and other sex chromosome abnormalities. Here you can see the findings from an updated meta-analysis that was published earlier this year. And you will see that the detection rate for the aneuploidies I just mentioned are all above 95%, with false positive rates well below 1% for each condition. For example, you can see for trisomy 21, the table shows the detection rate of greater than 99%, with a 0.04 false positive rate by NIPT. Certainly compared to the 5% false positive rate for traditional screening options, such as the first trimester combined test, you can see that NIPT clearly meets the goal of providing a screening test with a high detection rate for common aneuploidies with a very low false positive rate, which potentially leads to fewer diagnostic procedure-related miscarriages following amniocentesis or CVS. Next slide, please. So this is truly a rapidly evolving field, and Illumina is certainly proud of our contribution to the scientific literature describing and supporting the use of NIPT by whole genome sequencing. As we continue to be innovative and strive for an even better NIPT and better experience for women and their partners, their families, and their providers, we are excited to introduce the VeriSeq NIPT solution. Next slide, please. So CENTOGENE CENTO NIPT utilizes the VeriSeq NIPT solution. So I'd like to review a few of the key advantages of this test and what sets it apart from other NIPTs. Next slide, please. Yeah, thank you. So the VeriSeq NIPT solution is a screening test for the detection of trisomy 21, trisomy 18, trisomy 13, and sex chromosome abnormalities, including monosomy X. So with this NIPT, you and your patients can have highly accurate results that you can be confident in with an industry-leading low failure rate, providing more results for more patients. The VeriSeq NIPT solution is supported by a large clinical accuracy study, which I will review with you. And you and your patients can benefit from fast turnaround time. And this improved turnaround time is due to several advances that allow this to be a streamlined and automated test with CIVD mark sample prep and analysis. It's easy for laboratories such as CENTOGENE to implement. Illumina does provide on-site hands-on training and continued support to CENTOGENE as our VeriSeq NIPT partner. Next slide, please. So there are three key features of the VeriSeq NIPT solution that I want to briefly discuss. This includes a novel feature known as paired-end sequencing, a fetal fraction estimator, and the IFACT QC metric. Next slide. So paired-end sequencing, this is an improved method to determine the sequence or the genetic code of each of the cell-free DNA fragments in a maternal blood sample. With the paired-end sequencing, both ends of each fragment are sequenced rather than just one end. So compared to NIPT using single read methods, this paired-end sequencing allows for better alignment, meaning better mapping of the cell-free DNA fragments to determine which chromosome region they represent. And even more importantly, by using paired-end sequencing, we can determine the size or the length of each cell-free DNA fragment. Next slide, please. So this advantage of paired-end sequencing is very powerful because studies have shown that in a maternal blood sample, the shorter cell-free DNA fragments tend to be fetal in origin, while longer fragments tend to be maternal in origin. So remember, all NIPTs analyze all of the cell-free DNA fragments together, the maternal and the fetal fragments. By using paired-end sequencing, the shorter fragments can be selected in a way to boost the fetal signal, and this helps to provide highly accurate results. So we have the fragment size statistics, which determine if there is an increased proportion of shorter and therefore more likely fetal fragments coming from a chromosome of interest. And if you go to the next bullet point. So then there's also counting statistics, which determine if more than an expected number of reads are mapped to each of the chromosomes of interest. Again, for example, chromosome 21. And last bullet point. So the fragment size statistics and the counting statistics are combined to produce a final score, which is then used in the reporting. Next slide, please. So I used this slide, and also if you go to the next slide, I show these really just to remember to tell you that the VeriSeq NIPT solution does provide a reported estimate of the fetal fraction. And this is based on using data from two methods which are combined together. One of these methods, again, uses the power of the paired-end sequencing to determine the fragment size distribution. Next slide, please. And the last key feature I want to review with you is IFACT, which stands for Individualized Fetal Aneuploidy Confidence Test. This is a quality control metric that is assessed for each individual sample to ensure that there's enough sequencing quality and quantity to provide a confident result. IFACT allows results to be provided for the maximum number of samples, including samples with low fetal fraction. Samples that do not pass this IFACT quality metric threshold do not provide a result. Next slide, please. So the figure on the left, which is from published data, shows that the fetal fraction, represented here by the blue dotted line, the fetal fraction is fairly stable throughout the first trimester and early second trimester, and then starts to increase more significantly starting around 20 weeks gestation. So some NIPTs use a minimum fetal fraction cutoff, such as 4%, meaning that all of the samples with a fetal fraction below this cutoff, represented here by the solid green line, these would all be failed because of their fetal fraction alone, with no results provided. These strict fetal fraction cutoffs therefore can lead to higher test failure rates even upon redraw, meaning that if the woman's first NIPT fails, she then comes back to you and provides a second sample so that the NIPT can be attempted again. But studies have shown that up to 65% of redrawn samples again fail to provide a result. This whole process can really lead to increased turnaround time, increased patient anxiety, and decreased overall satisfaction from the patient and the provider. And in the end, you and your patient may still not have an NIPT result. Next slide, please. The IFACT metric allows us to evaluate each sample, even those that would fall under another lab's fetal fraction cutoff, and individually evaluate the quality and quantity of the sequencing data relative to the fetal fraction of that particular sample, and determine whether or not there is enough information to provide an accurate result. IFACT therefore allows results to be provided for more samples, even those with low fetal fraction, as long as there is sufficient sequencing data, resulting in a reduction of the test failure rate. Next slide, please. So here's an example. IFACT is a dynamic threshold, which is represented by the solid black curve that you see here. And let's imagine that there are two samples, both with the same low fetal fraction. These could be samples that would not pass a different laboratory's required fetal fraction cutoff threshold, and therefore would not have a result provided. But the IFACT quality control metric also takes into account the sequencing data or coverage. So for the samples that's represented here by the green dot, there was sufficient coverage for that particular fetal fraction. The sample passes IFACT and a result is provided. For the sample that's represented by the red dot, at the same low fetal fraction, there was not enough coverage for that sample, and the IFACT metric fails. When there's an IFACT failure, we do recommend that the laboratory rerun the original sample, because a higher coverage may be achieved on the second run, which, if it's sufficient, can allow IFACT to be passed, and a result may be provided from the original blood sample without asking the woman for a second attempt on a redrawn sample. Next slide, please. So why is it important to have an NIPT that provides highly accurate results and a low test failure rate? Studies based on other NIPTs have shown that among the failed samples, there's a relatively high rate of aneuploidy, as much as 22%. If an NIPT has a high failure rate, it's not meeting one of the main goals of NIPT, and that is to provide a high detection rate for fetal aneuploidy. So when an NIPT has a high failure rate, the test's actual sensitivity may be less than the claimed sensitivity because of all of the affected pregnancies among the failed samples, which are usually not taken into consideration when the laboratories are calculating their reported sensitivity. And as I mentioned before, redraw for NIPT is often ineffective, and the whole process can lead to increased turnaround time, more office visits, and increased patient and provider frustration. Next slide, please. So those are some of the key features and advances of the VeriSeq NIPT solution that set it apart from other NIPTs. Next, I'm excited to share with you the results of our clinical accuracy study. So our clinical accuracy study included 3,107 samples with known clinical outcomes. And as you see here in the red box, only 21 of those samples had a quality control test failure. So this gives us an industry-leading low test failure rate of 0.68%, which, as I mentioned before, is very important for patients and providers and is a key advantage of this NIPT compared to others. I do want to point out that this 0.68% failure rate is based on testing just one aliquot from each sample that was used in our study. As I mentioned before, our recommendation is to rerun a second aliquot or a second proportion of the original sample if the original sample initially fails. Samples that are run a second time, as I mentioned, can provide results because a rerun might address potential issues with the sample preparation or low sequencing coverage from the first run. But due to this design of our clinical study, we were not able to rerun those 21 samples that failed. It's very possible that some of those samples would have provided a confident result if they were run a second time. So therefore, in actual clinical practice, the overall test failure rate may be even lower than the already low rate of 0.68% that was seen in the clinical accuracy study. Next slide, please. So highlighted here in the red boxes, you can see that the average gestational age of our study population was approximately 12 weeks, and 82% of samples were drawn in the first trimester. We think this is important because we wanted to have a sample set that is representative of what is seen in an actual clinical setting, since most women are having NIPT in the first trimester. We also purposely wanted to have a challenging sample set to really rigorously test this VeriSeq NIPT solution. So focusing on early gestational age samples is reflective of actual practice, and it's challenging because of the lower average fetal fraction seen in early gestational age samples, which makes it more difficult to accurately detect fetal aneuploidy. If you look closely at the study designs used to report performance of other NIPTs, you may see that the mean gestational age of samples is higher, which may not adequately represent performance at earlier gestational ages. Next slide, please. So regarding our results, here are the performance metrics. For trisomy 21, we had a sensitivity of 98.9% with a specificity of greater than 99.9%. For trisomy 18, a sensitivity of 90% with a specificity of 99.9%. And for trisomy 13, a sensitivity of 100% with a specificity of 99.9%. Next slide. The concordance for the fetal sex and sex chromosome aneuploidy is extremely high. Here we're showing that the sex chromosome results that were obtained by the VeriSeq NIPT solution were highly concordant with the outcome data, which was based on either physical examination or the actual cytogenetic or chromosome results for the fetus or baby. Next slide, please. Overall, the clinical accuracy study shows that the observed sensitivities and specificities for the VeriSeq NIPT solution are vastly superior to traditional screening options, such as the first trimester combined test. The VeriSeq NIPT solution uses the IFACT quality control metric, which enables the detection of fetal aneuploidy at low fetal fractions, even fetal fractions of 4% or less. And in the clinical accuracy study, we did indeed detect fetal aneuploidy in samples with a less than 4% fetal fraction. And last, we also showed that the VeriSeq NIPT solution has a very high specificity. In fact, a specificity of 99.9% or greater for trisomies 21, 18, and 13. So we've therefore shown that this NIPT does have a very low false positive rate, which is a significant improvement over traditional screening tests. Again, fewer false positives may result in fewer procedure-related pregnancy losses that are associated with CVS and amniocentesis. And over to Professor Power.
Yeah, thank you, Christine. So there's a lot of technical information, but I think this is the very important basis to be confident about the right choice in which test to choose. And of course, we have evaluated the technologies like HERT with competitors and came up with VeriSeq as the optimal solution for us and for you to offer. Part of the reasoning is summarized in this table. So you heard about the CV-IVD label, which gives us really the highest quality in production and a huge support by a big company in the background. We look at other tests in the field. We see that for sure the turnaround time is one very important parameter, which is usually around 5 days, could take sometimes a little bit longer, but it's easy to meet the 5-day promise with the CENTO NIPT. There's no difference in the coverage except for a couple of small microdeletions, which in our discussion played a minor role because they are so rare that a full screen on these abnormalities usually does not improve the sensitivity of the test. But as Christine said, the test failure rate here exemplified for T21 is really one outstanding performance characteristic of CENTO NIPT powered by the very sick Illumina technology. And as you heard, this not only is something we can substantiate in pure numbers, but this will give back to your families and pregnant women a value in better diagnostic interpretation, less redraws, and less uncertainty about a test that you want to pass with a high confident result. So why do we really propagate this bundle? It's lower in the test failure rate by 30 to 50% as compared to all the other products. And the redraw is an option we usually don't need, or we can almost exclude that we need it. The only care you have to take is that the sample, which is a special vial, is drawn accurately and the blood is submerged in the solutions we provide you with, and so we can exclude any damage to the sample during transportation. So the low repetition risk as well avoids unnecessary invasive testing with the risk of pregnancy loss, and so in the end this gives an added value for your patient and you in offering this test together with us and our expertise. Now, if you look at the workflow, our team worked hard to make it as easy as possible. So we have designed a shipment box that can be ordered at dmqc@centogene.com, either by email or you give us a call, and we will send out a batch of pre-labeled samples where you can collect the maternal blood using those track tubes, which are special tubes with Vacutainer technology. The next easy thing for you is that you can register the test with the barcode provided on the vials and in the boxes, and so any mix-up of samples and names is excluded, and so you can pack, bundle your parcel, and ship it to our central laboratory in Rostock, Germany, by FedEx, which is organized. And then upon reception, we can really run the whole analysis in a maximum of 5 days, and you will get the report ready for download in our CENTO portal again, where you also registered the order with the adjacent result, and you will in parallel be invoiced for the sample by email. So we are sure this is a very lean and efficient workflow to handle those precious samples and make sure there's no information, neither material gets lost on the way, and can really deliver together results requested. If we look on the key messages, you learned right now that CENTO NIPT is safe for mother and child with no risk for miscarriage. It's a very early test, so you can start at week 10, and with this fetal fraction measurement, we are always aware whether the sensitivity of this fetal material is given, and so there's more trust in this aspect of the test. As said, we are as fast as the competitors, And for sure, everything is supervised by genetic disease experts that know how to process these samples and how to communicate results in a global market with language skills in not only English, but as well French, Spanish, Portuguese, German. And so this helps us as well to communicate what results, because it's not only the test, it's also very important that the medical reporting just touches on the spots you're expecting and that we don't have miscommunication on potential results. Therefore, we worked as well, of course, in the report format and information, and you get in principle, two major results. Apart from the patient identifier in the red box, we will have a readout on the detection of the potential aneuploidies, and there is a clear verbal statement on the presence or absence of aneuploidy. Moreover, you get an indication on the fetal fraction, so you can see that the test was valid as we did before, and there is an indication on the fetal gender. Moreover, the report contains a clear verbal statement on the absence, in this case, of chromosomal abnormalities and autosomal abnormalities, but as the clinical picture, the clinical information always drives what the result of a test can be interpreted for. Of course, we always take account on this information. If the pregnancy is has any ultrasound abnormalities, of course, we will not exclude the genetic risk, but maybe suggest a follow-up test, which I already presented in the introduction. While if this is a normal pregnancy with the wish to exclude an aneuploidy risk, of course, this statement would say that we don't see an increased risk for any of the measured chromosome aneuploidies. On the other side, and this is just the second page, there's a lot of additional information on technology where you can really go into those details that Christine mentioned before. So each test has its own error limits, and they are given here as confidential intervals. And so the sensitivity of this particular test is being able to be discussed with you if needed. Usually you take the information from the first page, but there is, as said, within the test, more value than just a verbal statement. For the abnormal test, I have brought up these examples where we detect the trisomy 21. Again, a very clear, very obvious abnormal result in the columns of the table, and followed by a very clear statement that we have a test that demonstrates the presence of a trisomy 21, which should be revalidated in this case by an invasive testing if the physician or the gynecologist agrees. If the ultrasound is totally in line with this finding, it's upon, of course, the referring physicians how to react on these test results. But from a genetic point of view, we would always recommend to do a validation test in these instances. So that's kind of the reporting world we can provide with the whole range of interpretation and documentation in our written reports. And now still we have prepared some considerations about guidelines and counseling scenarios, and that's once again Christine.
Thank you. So we wanted to end by discussing some of the society guidelines and some of the counseling considerations. So many medical societies around the world have published guidelines regarding the use of NIPT. And these guidelines may vary from group to group, and they've certainly evolved over time. But there are a few consistent themes in these guidelines. One of the themes is the increasing support of offering aneuploidy screening, including NIPT, or diagnostic testing to all women. Another theme is regarding the test failures. So many groups are recognizing the implications of the test failures, and some have recommended that after an NIPT failure, that alternative testing, including diagnostic testing, should be discussed with the patient because of the increased risk for aneuploidy based on the test failure. And last, and this is one of the most important points that we want to make today, Professor Bauer also just touched on this, is that NIPT is a screening test. It's a highly accurate screening test with advantages over the traditional screening options, but false positives and false negatives do occur, and therefore diagnostic testing should be offered to patients with a positive NIPT result. Next slide, please. We recognize that the practice and the guidelines vary across the world. However, over time, more and more medical societies have become more supportive of offering NIPT as a primary screen to all women. For example, in 2015, the International Society for Prenatal Diagnosis stated that cell-free DNA screening as a primary test offered to all pregnant women is an appropriate option. Next slide, please. So I'm a genetic counselor, so of course I believe that appropriate pre-test and post-test counseling is very important for women who have had or are considering NIPT. NIPT does not screen for every possible condition or adverse outcome. So of course, it's still important for doctors and other healthcare providers to obtain and evaluate the woman's medical history, pregnancy history, and family history, and to take the results of other genetic tests, such as carrier screening tests, as Professor Bauer mentioned, and other genetic tests into consideration. But as part of pre-test counseling for NIPT, a woman should understand the benefits and the limitations of a screening test versus a diagnostic test. She should understand the chance of false positives and false negatives associated with NIPT, and she should be informed that a diagnostic test would be indicated if the NIPT result is positive or abnormal. Next slide, please. If a woman has a normal or negative NIPT result, she should be reminded that the test is highly accurate for the tested conditions, but again, it does not screen for all possible chromosomal or genetic conditions. She should be reminded of the possibility, which is often very small, of a false negative result. And it's always important to consider the NIPT result along with all of the available clinical information. So, for example, even after a negative NIPT result is received, there may still be a reason to offer diagnostic testing, such as if there's presence of fetal abnormalities or structural anomalies detected by ultrasound. The NIPT result might represent a false negative, or there may be another chromosomal or genetic condition that's present that's not screened for by NIPT. And last slide. But after an abnormal or positive NIPT result, as I mentioned earlier and Professor Bauer mentioned, diagnostic testing should always be offered. And again, that is clearly reported on the test report, or clearly included on the test report. Again, it's important to still take into consideration other clinical findings, such as ultrasound findings, gestational age, and any other history or relevant test results when following up on abnormal NIPT results. And I believe that this, oh, go ahead, Professor Bauer.
There is still just an illustration at the end of our joint presentation, and this is about how we designed just the package. So if you want to offer CENTO NIPT to your patients, we can provide you with a very informative flyer for the patient that gives a short wrap-up of the crucial information on test and workflow. We have a more extensive physician brochure you can request. And then if it's about the samples, we have designed these ready-to-use sets of NIPT boxes, which will be shipped to you upon request and can be just displayed in your offices wherever you need it. So feel free to contact us, and we will be happy to help you with this information and shipment materials and logistics, which is our expertise in the whole process. So at that point, first of all, thank you, Christine, for this huge and very impressive technical contribution and framework of how this is set into counseling and medical services. For you, thank you for your interest. And now I think we have a couple of questions to answer that can be discussed. So just use the chat function of the browser to send in even more questions. And maybe we can start with a couple of questions I received already. One is NIPT failure due to decreased fetal fraction is observed in trisomy 13 and 18, but is it in trisomy 21 too? So maybe Christine, you want to comment from your extensive validation analysis on that question?
Yes, and I'm sorry, I was looking at a different question. Can you repeat the question?
The NIPT failure due to decrease of fetal fraction is observed in trisomy 13 and 18. But is it observed in trisomy 21 too?
In general, it is more difficult to detect aneuploidy accurately with lower fetal fractions, and that could be for any of the aneuploidies. It is true that trisomy 18 and trisomy 13 tend to just generally have lower fetal fractions, so that is true. Again, one of the advantages of the VeriSeq NIPT is that we're not basing failures just on fetal fraction. You know, we do look at a lot of other information, including the sequencing data, to see if there's enough information both from the fetal fraction and from the sequencing data to be able to provide a result.
Okay, maybe. Yeah, just.
I'm sorry. I do see one other question here that I can also address. So there's one question that says, can the performance metrics for the autosomes, specifically the specificities for trisomy 21, 18, and 13, be found in any publication? So I would answer that and say that there is a publication in process that will address the performance metrics and the clinical accuracy study that I did review today. And also, those performance metrics can be seen in the report and are also included in the VeriSeq NIPT product insert.
Okay, so I've seen a question about a relation of body mass and fetal fraction, and yes, the question is well addressed, since we know this relationship with higher body mass index and a trend towards less sensitive tests, which is correlated with the fetal fraction. We see that, but the advantage of VeriSeq and Center NIPT is that we can really see the fetal DNA, and like that, we can always tell you whether we did measure something of the fetus or not, and usually we can see those traces and enough traces to come up with a report. Another question I should address is how we can care on instrument downtime and still keep the touch, and what about instrument redundancy? So In our current setup, we have done a lot in maintenance and the setup to keep this risk as low as possible, but of course we cannot always be sure that not any failure will affect the liquid handler or the sequencer. So there is close communication with Illumina as our service provider, and in case there is something we cannot fix within one day and we have next day service contracts, we will come up with a substitution solution for those things. So that's of course not possible for the liquid handler. Then we would have to send our samples at the moment, which is arranged as well. But for those incidences that could happen by our experience, I think we can safely keep on average within the 5 days. The turnaround time, of course, is not something where we guarantee that we can always keep all samples within that time. Sometimes we see problems in processing, but on average it's kept up on a very high level. So that's our promise, and so far running those samples, we kept the promise as well. So maybe Christine, you've seen another question.
Yeah, there's another question here that asks, does NIPT include sex determination? The Verific NIPT solution does allow for sex determination, so being able to tell male versus female, and again also look for aneuploidies involving the X chromosome and Y chromosome. So this would include detection of sex chromosome aneuploidies like monosomy X or Turner syndrome, triple X, XXY, and XYY. Those can be reported with this NIPT.
Okay, so I have another interesting question addressed to us, whether we provide genetic counseling for patients with positive NIPT results. To be honest, the genetic counseling should be very close to the pregnant women, especially if the test is abnormal, because then you have to organize all the management around this pregnancy with an abnormal test. And so for sure we can at least use our network to find genetic counselors nearby to offer this service. And the abnormal ones maybe is something we can even offer remotely, but especially the abnormal results, they need a genetic counselor and genetic services nearby, because there's a lot of consequences to discuss and understand in a very short time. So that's something you have to look up when you try to establish NIPT screening in a region where this service is scarcely available. Please contact us and we try to help you with our network. So anything still on your list, Christine? A question not yet
looking at the questions, I think I've addressed most of those that I can.
Yeah, so I have the same impression. So, but thank you all for this interesting feedback and these elaborate questions, which are really showing me that not only the interest, but as well the knowledge of NIPT is already very mature, and so happy to work with you together with this exciting product in the near future. Having said that, I think we close this webinar, and thank you all for your attention. Feel free to contact our customer services with any question not answered yet, and so have a good day. Goodbye.
Thank you, everyone.